response. BCIA is bringing this to you with the help and the support of Dr. Tom Collura. We are so excited that you're here. This is the biggest group that we've ever had, and we're very, very happy to be able to offer this opportunity to you today. A little bit of housekeeping. You will receive an email from me, probably not until tomorrow, that gives you a link to the evaluation. This is very important because this is an accredited presentation. So an evaluation is very important. If you've paid for the CE exam, the additional $15, you will also get a link to the exam. This exam, you must answer every question correctly at the very end of it. When you get through it, you won't be able to move on to question 2 till you get question 1 right. So once you work through the exam at the very end, the last page, that is your certificate. So you print out that sheet. It shows then if you get audited in research or whatever you need it for, that is your certificate. So it's a little bit after our starting time of 2 o'clock, and we have a pretty good attendance here today. So without further delay, I'm going to mute myself and turn you over to Dr. Tom Collura. Thank you, Dr. Collura, for joining us.
Okay, thank you very much, Judy, and I'd like to thank everyone who's here. I'm going to be using this GoToMeeting, GoToWebinar technology here, which is sort of interesting because I'm talking to my computer and getting basically no feedback from anything. So I'm going to send Judy a quick message asking if she can hear me, and if everyone can hear me, then we will be able to begin the presentation. I'm Tom Collura, and what we're going to be talking about today is some material that I put together for a term paper for a course I was taking in pharmacology. And I was given the opportunity to look at EEG and QEEG in relation to medication and the effects of medication. And although this topic gets connected with neurofeedback and is related to neurofeedback, our focus will not specifically be neurofeedback, but will be using EEG and QEEG as we look at how clients are responding to medication and how they might respond to medication. This, of course, is a didactic presentation, so I will not be talking about any particular products or software or any of those types of things. I'll be presenting some science and some published literature, and I'm hoping that everyone finds that interesting. So with no further ado, we'll proceed and start to look at this topic. Let me click on here. Okay, as an overview, we're going to be looking at factors that influence the EEG. What is the origin of the EEG? And what is the nature of the types of things it can show us. And we're going to look at EEG considerations regarding medication for 3 particular situations, the first being ADD, ADHD, and the second being depression, and the third being some information on migraines. And then we're also going to look at some general recommendations for how we might move forward and how this information might be useful. First, I want to look at the general factors that influence the EEG. The way I like to think about it is that there is a what we call an endogenous EEG, the basic person's EEG, which is primarily determined by what I would call epigenetic factors. And these include the genetics of the individual, the physical origin of the EEG, the physical basis of the EEG, and it might also include influencing factors such as diet and things like that. And of course, medications would start to fit into the physical layers that affect what would be the EEG, given that there were no other alternative changes, influences. In addition to this, I look at internal goal setting as something that can produce EEG deviations. For example, an individual who is stressed and is living under the stress of goals would possibly see deviations due to their internal goal setting. Someone also who meditates, for example, and is doing relaxation training types of things would also see their EEG adjusting to those types of things. And then finally, I identify environment specifically as things which will affect the EEG. And we see a lot of influence, for example, PTSD, things leading to anxiety, things leading to a depression. Environmental stressors, without a question, are going to play a role in creating all sorts of deviations and variations in the EEG. So we don't think of the EEG as something that just sits there in a static form. It really is a highly variable and influenceable signature of the individual. And we also tend to look at EEG deviations in terms of some different types of classifications. Certain things might be maladaptive, changes that are not for the better, for that person's betterment, if you will. Certain changes are adaptive and allow the person to function better in certain circumstances, and we'll talk about some of those. Deviations might be coping. We might see those in cases of chronic disorders or chronic stressors. We also may see compensating deviations, things that are changing as a result of illness or other types of demands. So when we look at the EEG, it's helpful to think, I believe, in terms of this constellation of factors and influences that are going to produce these changes, deviations, individual signatures of the individual's EEG. And I'm going to be reviewing a range of literature and some published material that helps to elucidate some of these factors. Now, one of the main things that I like to think about in terms of the EEG, and this tends to be more of a dynamical and an electrical thought process rather than a chemical one. I'm not a highly knowledgeable about the various neurotransmitters and a lot of the chemistry. I tend to think more in dynamics. And what we have, and as a general rule in the EEG, and this was first elucidated by Barry Sturman and has been developed, by others, is that the EEG and the brain at various points in time are in various places along this continuum. And the continuum includes whether a location is more relaxed, which means it's producing low frequencies, high amplitude waves, a lot of synchrony, and less neuronal independence. And these are your theta states and your low alpha states. And as the brain becomes more excited, more activated, we begin to move to the right into the region that I look at as concentration, where you have lower amplitude waves, higher frequency waves, less synchrony, neuronal independence. So there is a continuum of dynamics between a highly locally synchronized set of states on one hand, and on the other hand, a lot of neuronal independence and high frequency, low amplitude. And we can begin to identify pieces of EEG and moments in time, as well as moments in locations in space, as being somewhere along these continua. And one important factor is that the left side, what we call relaxation, alpha and theta, involve a lot of involvement of the thalamus in connection with the cortex. We have a lot of thalamocortical interaction on the left. And from our knowledge of the thalamus, we know that there are GABA is a very important neurotransmitter for modulating this cycle, and starving for GABA tend to struggle with this. We do see that in the, for example, alcoholics who have a high frequency, low amplitude EEG. A lot of times they're drinking in order to move back down on this continuum. And on the right side, we have more cortical connections, which would tend to be more serotonergic epinephrine type of transmitters, and cortical communication. And what's important for healthy brain functioning is that the brain can move back and forth between these states in a fluid and flexible fashion, and that it's not stuck or locked in any one position. So when we look at EEG with relation to possible use therapeutic medication, we can try to identify where a client is on these continua at various brain locations. And then this will help us to medications might be more helpful. Obviously, for example, if you're on the left side, then a stimulant might be appropriate. And if you're over on the right side, then a sedative or something more along the lines of a depressant might be indicated. And if you're simply stuck, what we're going to find is that some people are beginning to use anticonvulsants simply to help the brain restore regulatory mechanisms which have been compromised. I do want to pass through the concept of phenotypes. I do encourage people to understand them and to identify them when possible. What we're going to see as we go through this material is that a lot of the medication-related EEG falls nicely into phenotypical categories. These are the main phenotypes that were identified by Jack Johnstone and Jay Gunkelman in their publications. Martijn Arns has also begun to look at these carefully, and there's some beautiful literature which is cited in the end of this talk on how phenotypes can help predict drug response. But just to kind of quickly go through them, diffuse slow, of course, is the slowing associated with either pathology or toxemia, injuries, these types of things, poisoning. Focal abnormalities are local disturbances that would disturb local function but are not epileptiform, and this would include localized slowing or localized fast activity. And one thing we will learn is that these can be localized to individual brain locations, such as the anterior cingulate, as one notable example of a location where a focal abnormality is a very telltale sign and can be used to determine. Mixed fast and slow is a phenotype in which we have a lot of fast activity, basically riding on slow activity, and we don't have that mid-range band. That shows that there's a problem with the GABAergic mechanisms, and we are not seeing alpha in the midband, and this is very telltale. Frontal lobe disturbances, excess slow, we will see shortly, are profoundly important for ADD, ADHD, and diagnosis thereof. Frontal asymmetries, we will see, are very important for mood and can be used to help determine what types of medications might be helpful in mood cases. Excess temporal lobe alpha is a distinctive phenotype that we see occasionally, and what I will mention later in a little bit is that it tends to be associated with OCD and other types of disorders of flexibility. Excessive beta is a very important thing to look for, to be aware of. You do not often see it necessarily in a QEEG. It can be visible in an EEG by eye, but sometimes the amount of beta is not sufficiently large that a person would show up as highly deviant on a QEEG map. But you want to learn to recognize that primarily visually. Generally low magnitudes. Now we have a low amplitude EEG. Typically they tend to move toward the high frequencies, but not necessarily. Persistent alpha is a very interesting variant. It could happen as a sort of a native style or a native trait of an individual, but it can also arise as a reaction to, for example, chronic pain or even chronic anxiety. So a coping mechanism or a compensating mechanism. where an individual is responding to either an internal state of anxiety or pain, or possibly to an external circumstances that are leading them toward this discomfort, and they lapse off into an alpha state in order to compensate or cope with it. Epileptiform, of course, every neurologist knows how to recognize epileptiform. Whenever you see epileptiform EEG, you immediately want to be in touch with a neurologist, preferably a clinical neurophysiologist, who will do visual inspection of EEG waveforms. And in those cases, you definitely are looking at a medical type of intervention in addition to any mental health type of intervention. Faster alpha variants, but not low voltage. Those are your fast peak frequencies. Your alpha can be 11 hertz, 11.5 hertz, 12 hertz. I even see it at 12.5. These are very, very interesting. Sometimes they're associated with high performers, sometimes not. And finally, I've identified and just decided to pick out a diffuse alpha deficit. And I do at times see someone whose EEG looks entirely regular, but there's just not the alpha that we're looking for. And it's a little different than mixed fast and slow, because the amount of fast and slow is otherwise normal, but what we simply see is there's a dropout of alpha. So these reflect different genetic predispositions, as well as then the response of the individual to stressors and to environmental situations, and possibly also to medications in certain cases, as we'll talk about. So I want to jump right in and get our feet wet a little bit, talking about some of the most common EEG deviations, things that need to be really at the tip of your tongue and ready as soon as you're confronted with any type of client. Where there is depression reported, there are at least two types or origins. One is the asymmetric frontal alpha, and that's very well documented, and we're getting lots more exciting results, quite frankly, using Loretta for measuring the activity at different brain locations, the dorsolateral frontal areas. And this, of course, draws on the work of Richard Davidson and Peter Rosenfeld, and the Bayers have used neurofeedback for this. But what we're going to see is that the presence of asymmetric frontal alpha is a positive indicator for likely response to conventional antidepressants. And but there are other forms of depression in which you don't see this asymmetric frontal alpha, but what you see is a beta abnormality. And it could be an excess, and it could be a deficit. They occur in both types. And again, this gets back to this whole concept of coping mechanisms, compensating mechanisms, personal style. As we all know, depression could be a result of just about any other disorder, axis 1 or axis 2 or medical. So it's not at all uncommon for someone, say, with an eating disorder to be depressed, or someone with chronic pain to be depressed, or someone who has anxiety can get depressed about the fact that they have anxiety. So you will be seeing, there's no cookbook about what you're going to see in any depression case until you look at EEG and see where you are. I'll just mention in passing the OCD documentation, and then one of the references is cited here at the end of this talk, that we do see in the orbital frontal areas and in the temporal frontal areas, where this alpha then basically indicates that those regions of the brain are what I call checked out. They're not functioning in the normal coordinated fashion. And so these areas that are responsible for such things as planning and integration of memory with planning, picking the next tasks, this disorder is reflected in those types of EEG issues. Now, the third one, ADHD, is very interesting. There are a lot of variants of ADHD, not just one or two. I hope to talk about all of them, at least a little bit in this talk. Everybody is pretty much aware of the theta to beta ratio issue in ADHD that we often, but not always, see an increase in the theta to beta ratio. But what we've learned more recently is that this really breaks down into a whole raft of specific issues. One is that there may be frontal slowing. And when there's frontal slowing, what that can mean is that there is a normal amount of activity, but that it's slower. For example, slowed alpha. So whereas alpha might typically be in the 9 hertz range with these kids who are coming in, it could be, they could have frontal alpha of 8 hertz or less, 7 hertz. So you'll actually see an alpha wave in the front at a low frequency. Now this, in a QEEG, will look like a theta to beta ratio is going up. But what's really happening is that the alpha is slowing down in front. And this can be seen visually in the EEG. A separate thing is frontal theta. And theta is different from alpha. It has a different morphology. It has a different cortical orthothalamic, and it's more often asymmetric. There may be coherence problems, and actually there may be excess coherence with frontal theta. Also, excess central alpha is another variant of ADHD. You see this big alpha peak in the middle, and these are not the same types of people who have the frontal slowing or the theta. And there's also a variant of ADHD which is a low voltage EEG. And interestingly, the rate of occurrence of low voltage EEG is higher in ADHD than it is in the general population. So this is a rather important or significant subgroup, even though it's a minority. Nonetheless, when it occurs in an ADHD population, it's considered to be profound and associated with that individual's particular peculiarity. Now, first I want to pass a little credit over to Jay Gunkelman, and because this is a didactic talk, I'm not going to be shy about citing other people's work. I'm giving full references and full credit, and so there's no confusion here. But I want to relate what Jay has to say because I happen to agree, and it sort of relates to some things I just said about 10 minutes ago. There is a reciprocal effect between low and high frequencies, and Jay says between alpha and beta, as the alpha generators are desynchronized, then beta is seen. And again, this looks like the curve I talked about. So during states of underarousal, when the brain is generally not aroused, they could both increase. But generally there's a back and forth effect. The arousal level does change the EEG changes that are expected, and this then is part of the heart of using EEG to predict how a person will respond. For example, if a person is under-aroused and you give them a stimulant, you might see alpha increasing. But in normal subjects, the stimulants decrease alpha. And in an anxious person, a low-voltage fast type of individual, the stimulant might not have an effect because this person is already in a highly aroused state, and giving them a stimulant would be kind of like giving a cup of coffee to someone who's already highly aroused. So there is, although there is a stereotypical response for each medication, we really have to think about individuals and the fact that an individual will respond in their individual way to the medication. And that's really the key, I think, to using EEG responses is not to say, oh, this medicine is going to do this to everybody, but rather to say, looking at this particular person, looking at their symptomatology, their personal report, their history, and their EEG, what medications might make sense. One benefit of this approach is going to be that it's going to be less important to mix up medications. One of my favorite commercials is for Abilify, which isn't even an antidepressant, but which they tell you for people who already are taking an antidepressant and it's not working, Here's another one to take. And obviously there's some irony in thinking along those terms. But what you're going to see is that if you use EEG to pick the medication, you go way beyond this typical 30% response rate. 30 to 40% is the typical response rate when you use disorders even to pick medication. So the standard model is disorder, pick a medication, see if it works. Almost 2/3 of the time it's not going to work. So they throw on more medications. Well, what we're going to see is there's a much better alternative to this. So first I'm going to review a little bit what the EEG changes are that you do see due to medications. And this gives us a little insight into what the medications are doing. For example, if we look at opioids, cannabis, PCP, typical antidepressants, they will increase slow wave activity. So they will generally move the brain over to the left side of the graph, create more synchrony, local synchrony primarily, and then you're going to see more slow wave activity. Barbiturates tend to produce paradoxically a rhythmic 18. Neuroleptics and tranquilizers generally seem to increase coherence. They can decrease beta, which makes sense. When the beta is associated with excess excitability, hyperexcitability, and anxiety, then decreasing beta is commensurate with a relaxing type of effect. Anxiolytics, anti-anxiety, tend to decrease alpha and to increase beta, which is an interesting observation, getting again to this idea of compensating and coping mechanisms. You'd think if something's going to make me less anxious that it's going to increase my alpha and decrease my beta. That does not happen to be the case typically. And SSRIs do increase frontocentral beta, and one of the conclusions that follows from this that happens to be correct is that if you see frontocentral beta, you do not SSRIs. They're not going to do well on them. There is a genetic underpinning to this. It's a COMT variant of the in their genetics, and they already have excess beta. They are spindling in beta, and if you give people with excess frontocentral beta SSRIs, they will get worse, and they will abreact. And I have seen situations where they had to drop out of school and go find another job and other things along those lines. Now, a question came up just before this workshop, which I slid into the talk. It's not in your handouts right now, but I went and dug it out quickly. I was asked about the atypical antipsychotics, of which Abilify is one, even though it is marketed largely as a supplementary antidepressant. It's not a happy medication. We all watch the Abilify commercial and through the side effects that they announce, including constipation. Extrapyramidal is motor problems, things that mimic Parkinsonism, problems with the pyramidal tracts, motor areas, sedation, tremor, restlessness, a whole constellation of nasty things. There are anecdotal reports of seizures and convulsions occurring in people. And I found a reference, which I've put the link on here for you, by Aurora and Arndorfer, and they reported in a 13-year-old boy that this boy began to twitch and have what were called spells when he was using Abilify. God knows why. I'm assuming it was for depression in a teenager of all things, a 13-year-old kid. I think everyone's depressed at some point when they're 13. But the EEG of this boy then showed what the neurologists call epilepsy and seizure activity, just widespread diffuse paroxysmal activity, nasties, indicating a loss of control, basically a breakdown of the regulatory mechanisms necessary to maintain self-control. So in this case, the Abilify appears to be working against the whole concept of self-regulation and stability, and actually pushing it in the other direction. So that's about all I know about that. I'm obviously not a huge fan of this approach. So what are the general principles we're going to use in trying to approach EEG or QEEG for these types of applications? So obviously we're going to record it and we want to classify it in some broad sense. I tend not to want to look at it in excruciating detail and just kind of with a litany of features. What I try to do is identify particular markers or traits. So in addition to the phenotype, the general style of the individual, maybe some dominant asymmetries which might be present, whether it's generally a low amplitude or high amplitude, fast or slow. I look for those types of things, and then focal abnormalities, of course, particularly involving the cingulate, in the insula, the frontal lobes, or wherever you see a particular characteristic. And then we want to associate it with likely mechanisms. It's important to build a story around it and say this is commensurate, it's consistent with this symptomatology, and I can create a picture of the fact that, even though one person may come in and say, I'm depressed, and they have one type of EEG altogether, another person might walk in right after them and say, I'm depressed, and you have an entirely different EEG. And so you want to associate that with whether they're reacting to things, what is the underlying physiology, how did they get there. And then you want to consider the effects of the drugs and how they might affect the EEG. And finally, what we'd like to try and do is assess the likelihood of a positive outcome. And we want to do that for medication. Of course, we'd like to really help that struggling in medication and mental health. Neurofeedback is obviously another possibility, and we're going to see in some cases it actually rises to the top of the list over medication. And also other therapies. For example, when you have PTSD, you may say, okay, I want to do EMDR, or I want to do a cognitive behavioral intervention. And you want then to have your EEG findings relatively consistent with this, so that you say, okay, it's reasonable that I can pursue this. And often they're used together, for example, is a proven combination for a lot of situations, particularly depression, anxiety, these types of things. And any one of them alone is not going to be sufficient, not for long-term results. So let's talk a little bit about ADD, ADHD. This will be the first disorder that we look at in a little bit of detail. There are at least 5 subtypes identified out there, probably more, depending on who you talk to. They do have distinctive EEG signatures, and I'll talk about them. It is prognostic for EEG biofeedback, and I'm going to cite a recent report by my friend Martijn Arns, who has achieved very good effect sizes picking EEG biofeedback protocols based on the EEG signatures. But also it's obviously prognostic for stimulant effectiveness, and we'll find some really good literature on that I'll mention and cite for you. And it may point to alternative medications. And again, there will be some citations, literature, some tables coming in the next hour going over these alternatives. As I said, in depression, there are 2 basic forms. One is this left-right frontal asymmetry. Davidson, Rosenfeld, and Bayer pointed that out. And the underlying factor there is that the frontal lobes have different functions with respect to mood and behavior. Essentially, the left hemisphere wants to be activated a little more than the right. The left hemisphere mediates approach behavior and the judgment that the environment is safe and that things are good. And the reason is, interestingly, because the left hemisphere is a sequential processor, and it looks at things one at a time. And it steps through everything, and it's basically there to say, I check this, I check this, I check this, yeah, we're fine, everything's okay, you can walk into the room. The right hemisphere in the front has a very different kind of a role. It's more responsible for withdrawal behavior, and the judgment that things aren't safe. And one of my sort of points of view is that because the right hemisphere is more spatial and integrative, parallel processing, holistic processing, if your brain is going to judge something as dangerous, it wants to do it in a hurry. So it's going to use a global evaluation, and it's just going to say, I just don't like the look of this thing. I can't tell you why, but let's get out of here. So if the right hemisphere is overactivated, then the brain is chronically going around looking for what's wrong with everything, and it winds up putting a person into a depressed sort of state. And long-term depression tends to be associated more with the inability to process positive information. And it's not necessarily that the brain has a stronger ability to process bad information. It's just that when something good happens, it doesn't process it. And that shows up in this asymmetry. And I want to recommend everyone go get Richie Davidson's new book with Sharon Begley called The Emotional Life of Your Brain. Go get a copy, read it, and he talks a lot about brain mechanisms and control of mood, control of emotion. And the other mechanism, general form that I mentioned earlier, is this issue of beta irregularities, which could be anywhere. Could be in the front, but also could be in the back. And you could have a beta excess or a beta deficit associated with an abnormality of activation, and underlying then, for whatever reason, a person be going into a depressed mood, and often it can be comorbid with anxiety. Depression is comorbid with ADHD, not uncommonly. A very high percentage of people with ADHD are depressed, have depression. And Larry Hirschberg at Brown and some of our colleagues at Tufts and Harvard are working on neurofeedback protocols which distinguish between these two forms and choose neurofeedback based on the signature that you're seeing in depression. I'm not going to talk a lot about anxiety, but I just want to point out that it's an interesting situation that, again, you can see various seemingly contradictory manifestations of anxiety. So a person may have excess beta or even high beta, and I know Mario Beauregard has looked at this a lot, if you have temporal parietal beta excess, not uncommonly you're going to have rumination, anxiety, ruminating thoughts, that kind of active, anxious, make anybody crazy who's near them, in addition to themselves. There's another form where you will actually see excess alpha, and the excess alpha is a coping mechanism. It's a compensating mechanism. And you know, it's the kind of person who's got their eyes wide open like a deer in the headlights, and you ask them, how are you? And they go, fine, fine, everything's fine. But inside there's an anxiety which is being masked or coped with by producing excess alpha. I do want to mention that if you were to train that alpha down, you run the risk of exposing the underlying anxiety. So this is one of those situations where an anxious person with excess alpha, you probably want to train down their beta first and calm them down, and then the alpha will come down along with it. And you will also sometimes see alpha deficits. And you'll see it in chronic pain, and you might see it in anxiety. I've run into a handful of people who don't make alpha. They don't like to make alpha. They don't like to relax. It's not their style. And again, it becomes a phenotype, essentially. It's like the mixed fast and slow type of phenotype. They might be at risk for substance abuse. They might be at risk for alcoholism. Oh, I already did that. Okay. So when we look at EEG-based pharmacotherapy, which is what I'll call this, I see basically two types of approaches which can be integrated, but aren't often. The one I'll say is phenotype-based, and that's what Martijn Arns and Jay Gunkelman and some of their colleagues have been working on, and there's some nice publications, and I'm going to walk through one of them and also give you citations for the rest. They have a beautiful chapter in Rob Coben's book, using phenotypes to predict ADHD medication responses. But I'll point out that they also are able to look at Z-scores. They're not blind to this information. It is helpful to verify a phenotypical judgment. And sort of the other approach, which is massively computer-based, is a purely QEEG-based response. And I'm going to show a paper by Di Battista and others, including Dan Hoffman. And this approach is typified by CNS Response, which is a commercial entity which will let you send them your EEGs, and under certain conditions, the most notable of which is that your client has to be free of medication. They have to be washed out. Another requirement is that they will only give this information back to a physician. They won't be feeding this back typically to your mental health professionals. And they also want some cash for it. So this is a fee-based mechanism, which again, now it's got a few limitations because of these factors. So if you're going to be trying to add this into your practice, you're more likely to use a combination of these two, do a QEEG, look at it, also classify the EEG, and then in consultation with someone who really knows their stuff, try and help choose medications or determine why medications have had the effects they have had. I will be talking a little bit about a migraine study. John Walker, I'll show the data from that. He compared EEG with medication effectiveness, and he also compared it with EEG biofeedback. And that'll be the last study that I summarized during this talk. And this is the one in particular in which EEG biofeedback comes to the forefront and actually turns out to be more effective than any medication, at least in Walker's own work. So let's just start to review some of the literature. All these citations are at the end of the talk. They're in your handout in APA format, so you can dig these out. This was a study that was jointly done with a group in Denmark and the New York University group. And they used a Loretta type of analysis and applied it to the data and looked at the source generators of the EEG when recorded from the scalp. And this is a general theme we're going to see a little bit during this talk, is that some of the best results come when we do localization, when we use Loretta or S-Loretta, or this one used Varetta, and it becomes then possible to identify the precise brain locations and patterns that are associated with this. And these are wonderful. You only need 19 channels of EEG, and with modern software technology, you can localize down to 5 or 6 or 7 millimeters where disorders are. And there are also Z-score databases for Loretta and S-Loretta, which can be used to really see how your client's brain function locally differs from normal. So this particular study found excess alpha in the corpus striatum and in the orbital frontal and the temporal frontal regions in untreated patients. So it's a very clear picture. These are people coming in with OCD symptoms, and when you look at their EEG, you see excess alpha. And that abnormality is seen to decrease when they're successfully treated with paroxetine. So there's then a EEG evidence that the medication is having an effect. We conclude these Varetta findings of an activation-deactivation pattern in cortical and subcortical structures in paroxetine responsive patients are in good accordance with data obtained using positron emission PET studies and the use of this feedback loop, the thalamo-striatal frontal feedback loop, being relevant for understanding the pathophysiology of OCD. So a very nice study showing an EEG correlate with a clinical disorder indicating the likely value of this particular medication, being paroxetine, and then showing EEG changes consistent with the benefit of that medication, and it all holds together with regard to that feedback loop involving the thalamus and the frontal lobes and the striatum in OCD specifically. Now I'm going to spend a couple slides, at least on Martine's latest paper. First of all, they did some very nice work, but also they did a good job of summarizing some of the literature. And so I felt I would just relay that summary information to you and cite this paper as being where that information was summarized. And if you go back to the paper, then you'll be able to find all the original citations. But what Martine's little group here did is they used QEEG and broke these people into different subtypes. And open label means everybody knew what they were getting. No one was hiding it. There was no blinding or anything. And they were just trying to break these people into groups. And this study was for neurofeedback, but there's valuable information about medications in this report. So here are some of these statements which were pulled together from a combination of the earlier work from this same group as well as work from others. ADHD patients with excess frontal theta EEG power and excess frontal alpha EEG power are more likely to respond to stimulant medication. And in fact, when we get to, if you look at Suffin and Emery, which is an earlier paper, they report a 90% response rate to stimulants when you have this class of kids. They also pointed out that low voltage EEG does occur more often in ADHD than in controls, and in those cases it points to a different mechanism. So these subgroups reflect either lower vigilance regulation or more unstable vigilance regulation, which would be contrasted with an auto-stabilization of attention. And that's the work of Hagerl. I'm pretty sure it's cited here. And these people are less responsive to stimulants. So by looking at the frontal EEG and looking for slow wave activity, you're going to be identifying those people who are going to respond to stimulants. And it's going to help to weed out those who are not going to be as responsive to stimulants, which is the low voltage group, for example. Another subgroup, excess beta or beta spindling. Now, I want to emphasize symptoms like ADHD are a lot like symptoms like depression in that there's a lot of reasons that little Johnny or big Johnny can't pay attention. And it's, you know, it's easy to sit on the outside and go, oh, gee, you know, you aren't paying attention. But is it because they couldn't get attention, or is it because they had to shift their attention around because they're nervous or upset or preoccupied? It's not as simple as, oh, gee, you know, not paying attention. So we do, for example, have this subgroup of excess beta or beta spindling. And these people are agitated. They are prone to abreaction. They're kind of a little hyper energized, and that's why they have ADHD. And we see a lack of improvement on impulsivity and inattention in response to stimulants. Now, I'm starting to work personally with a lot of parolees and probationers, sexual offenders in my clinical work. And these people have what I call impulse control disorder. There's a tendency to put them on axis 2, but I'm beginning to think that we need a different kind of view of axis 1. These are not just ADHD. They're intelligent, they can pay attention, but they lack control of impulsivity. And stimulants aren't going to help them. So you get one of these people who's in this excess beta or beta spindling modality, don't bother even trying to give them Ritalin or Adderall or any of these things. That's not what they need. And they don't need SSRIs either, because they're already making beta. Also, if you see the slowed individual alpha peak frequency, so someone's alpha, instead of being at 10 hertz, it's actually alpha, but it's at 9 or 8.5, they're not going to respond to stimulants either. Now you have to be careful, because if you're doing a theta-beta ratio and the alpha slides down to 8.5 hertz and starts showing up as a theta excess, and maybe shows up, the beta now is down because everything's sliding to the low frequencies, you're at risk of trying to throw stimulants at these. Visually inspect the EEG. Make sure you see whether it is alpha or theta, and where is it. Just sticking an electrode on CZ and taking a theta-beta ratio will not necessarily tell you whether you have slowed alpha peak frequency or whether you have theta. And they're going to respond differently to medications. And so this is considered a non-specific trait, and it's also non-responsive to antidepressants. And it's non-responsive to TMS, to transcranial magnetic stimulation. So this is another subgroup. It's a hyperactivated subgroup. Well, here's the group that Arns was looking at for his protocol breakdown, and I just show this because I think it's very illustrative when you look at the bottom of what they wound up doing with these people. There were 21 people, and a lot of them got an SMR protocol, and some got a theta-beta protocol, specifically 6 out of 21. 7 out of 21 were given a beta downtraining protocol because they had excess beta. Small number of them, 3 of them, got a frontal alpha protocol to go after excess frontal alpha. And 6 out of 21 actually wound up with alpha up training, which is a generalized relaxation type of training. So we can see that, you know, depending on the EEG, you might choose to do SMR training, which is, of course, the most common. However, sometimes you might be down training theta, you might be down training beta, you might be down training alpha, and you might be up training alpha. So life is not at all simple, but the good news is with the EEG, it's possible to start breaking these people into subgroups. And this study then showed a lot of really good improvement based on this personalized individual. So, for example, getting back to my earlier comment about the comorbid depression, up on the top bar graphs we have Beck depression inventory scores, and we see that the comorbid depression was effectively addressed in this population. Pre-treatment, the BDI scores averaged 20, and by post-treatment they were down around 7. But what's also very interesting, and I want to kind of put in a plea or a plug, clinicians should try to do this type of research. This is an N of 12, and we really need more clinically relevant research. That's one reason I'm starting to go into the clinic every afternoon now, going, you know, for a certification, licensure as a clinician, to kind of set a little bit of a tone that these results can be forthcoming without killing yourself or without going for $1 million in grant money. But this bottom plot, which shows a correlation between the frontal individualized alpha peak frequency and the percentage improvement in the BDI, it's very clear that the low frequency peak alpha is associated with low improvement, and the higher peak frequencies are associated with the higher improvement in the Beck depression inventory. So this is very much a individualized predicting factor that you could predict an improvement of as low as 0.4 and as high as 1 as a function then of where you started out. Where did you start out in that frontal peak alpha? So I'm just putting his abstract here in the handout so you have it available. It summarizes basically what I have said and talks about the development of personalized medicine and psychiatry, biomarkers, and the prediction of treatment outcome. And he cites Satterfield and Chabot and other very important authors in this regard. So let's look at DiBattista. He worked with Daniel Hoffman and a lot of people. This is a multi-site study, very high-end, psychiatric. All of these participants were psychiatrists, basically. A lot of good names here, Harvard, other locations. And what they did is they had, I don't remember the N, it's a high N, because these p-values are very, very strong. They compared what they call REEG, but they don't want to call it QEEG for various reasons, so they call it registered EEG. They're simply using the EEG to get these metrics and try and predict what medications are going to work, and they compared it with the STAR-D. And STAR-D is the gold standard psychiatric medication selection scheme. And STAR-D is what basically picks antidepressants based on symptom constellations or disorders, if you will. And this is a randomized study, and these use control subjects, and as you can read this and you can see that they had failed antidepressants, and they had failed, some of them had failed SSRIs, and they were randomized. And the total 114 subjects, 89 subjects could be evaluated. And when they used the EEG to pick the medication, it was significantly more effective than when the doctor just picked the medication sitting at his desk and flipping through the literature. The p-values here were 0.0002, which, as we know, it means you'd have to repeat this study thousands of times in order to get a result like this. And it was statistically superior in 9 out of the 12 endpoints. So this was a very convincing and powerful study, and there's no doubt that using REEG will definitely help to pick medications much more effectively than just grabbing at them, rather than, again, 30 to 40% effectiveness. This study was talking about 80 to 90%. And it's not because the drugs are any better, it's because you picked them better. And you gave the right person the right medication for the right reasons. And here, for example, shows when you use REEG, then the score which wants to be low, the disorder score is significantly lower over time. Over the weeks, you see a very steady, higher response in reducing symptoms. You use our EEG to pick the medication versus just using the medication that you pick off the list. And this shows us the satisfaction measure, a metric of how satisfied people were. And again, the REEG is considerably more satisfaction, the medication approach. And this is the one that's interesting. This is the one you want to kind of sit and stare at for a while. It shows the actual medications that were used for these patients. And as you can see, if you just use the disorder, you're going to give a lot of people bupropion and citalopram and venlafaxine. These are modern antidepressants. Very little gabapentin, very little dexedrine. That's never done. I see valproic acid, divalproic sodium. That's an anticonvulsant, valproate. Sometimes they're giving them lithium. None of them are getting methylphenidate from the psychiatrists, and none of them are getting selegiline by the psychiatrist. That left, you see just a handful of medications picked in the control group. And again, this is standard psychiatric process. Now on the right side, you see the REEG group. These are the people who used a EEG to pick. And look at the scattering. And what was done was this database has thousands and thousands of people in it. And it simply did a multiple regression type of analysis to determine when people had certain EEGs, which medications they were on seemed to help what symptoms. So what they found, for example, is a lot fewer people getting bupropion based on the database and almost nobody getting citalopram. But a lot of people wound up getting dexedrine because they might have been taking dexedrine for a different reason. But in the database, it said people who were depressed and had this EEG, so depressed anymore. So we've got 15 people taking dexedrine, 15 people taking gabapentin, 17 people getting methylphenidate, stimulant, Ritalin. So very interesting distribution of medications. Stimulants, amphetamines, anticonvulsants, no lithium, hardly at all, almost none of the standard medications, almost no citalopram, very little bupropion, almost no venlafaxine, but all kinds of other things. Atypical antipsychotics are being put in there. So, you know, this really points to a revolution in psychiatry, and we're just waiting for the shoes to drop or people to really kind of tune in on this. I don't know where the vested interests are. You'd think the drug companies would be perfectly thrilled to know which drugs work better. But I think this is a very, very solid study, and it's one that everyone should have at their fingertips and be ready to point to when you're talking with a psychiatrist or neurologist and you want them to help pick better medications. Now, Dan Iosifescu at Harvard has done a separate study looking at antidepressant response specifically. And he was a co-author with Di Battista, but this is a study that he published recently, 2011. And what he has done is started to look at other metrics. And he uses not just EEG power, he uses theta band and alpha band abnormalities. He has an antidepressant response index, which is something that he's kind of whipped up. It's kind of special for him. Accordance is a measure of the relationship between coherence and comodulation, other types of metrics. It's a complex metric. He's looked at source localizations, and he's looked at evoked potentials. And he then says there is a growing body of evidence that several EEG-based methods may be useful for predicting antidepressant response and eventually for guiding clinical treatment decisions. So again, very recent, Harvard University, very good study on predicting antidepressants. Here's a report from Pizzagalli, and he worked with Roberto Pascal Marquis, our friend who has developed the Loretta technology over the years, and also Richard Davidson is a co-author on this study. And this is an old one. This is over 10 years old. And what they've done is looked at the anterior cingulate cortex, and what they found, just to summarize, 8 channels of data. They looked at 18 unmedicated patients with major depression, and they compared them with 18 matched comparisons. And they were treated with nortriptyline. And in the research then, they found better responses, showed hyperactivity, higher theta, in the rostral anterior cingulate. And follow-up analyses demonstrated the specificity of the finding, and they found out that it was not confounded by age or by the severity of the pretreatment depression. And this was done using Loretta type of technique using localization of cortical current density. And so these support findings implying that activation of the anterior cingulate is a predictor of response in depression, and also the differential activity in the rostral anterior cingulate, the very front area, is associated with gradation. Again, this one points very strongly to the use of localization techniques using Loretta along with QEEG in order to identify which populations are more likely to respond. Now we're going to talk about Walker. This was a study on migraines. This particular study I felt was quite brilliant in design and in the conclusions that could be made. Interestingly, it is not randomized. It was not controlled. It was open label, but it was nonetheless able to produce very, very powerful statistics and very, very powerful results. So here's what Jonathan did. He took 71 patients with recurrent migraine headaches. They were all between 17 and 62 years old. All of these people had excess beta somewhere, 21 to 30 hertz in some cortical areas. He then offered them all neurofeedback and let them self-select. And 46 of these patients said, okay, I will take neurofeedback. And the remaining 25 said, I want to stay on my drugs. And that formed then the two groups. So what he did then is those who took neurofeedback as an option, he took the Q, and wherever they had excess beta, whatever sites, he gave them 5 sessions of alpha training at each site with beta down and theta down. So he basically relaxed those locations using good old conventional alpha training, but only on the sites that had excess beta. So the conclusion we're going to get to, and I'm going to say this conclusion 2 or 3 times because I think it's very, if you have clients who have recurrent migraine headaches and they are not responding to medication satisfactorily, and you offer them neurofeedback and they opt for neurofeedback, what we're going to see is they have a high probability of having their headaches reduced in comparison with the group that chooses to stay on drugs. So let's look at these results. Here are the sites. And again, this gets to the importance of individualized medicine. Look at the percentage of patients. 62% of them had excess at CZ. 58% had excesses at P3. 55% had excesses at PZ of absolute, etc., etc. 50% had excess relative power at CZ. 48% were at P4. So we see a lot of central and parietal excesses associated with these migraines. And then the list goes on. There's some in the front, mostly in the back. So these are the sites that Jonathan picks in order to do his relaxation training. So people are getting alpha training basically all over the head, primarily to reduce beta and to reduce theta secondarily. But you can see it's all over the place. There's no real fixed pattern except that it's a lot of central, a lot of parietal. Now this is the result showing the dramatic difference between the groups. The black bars on the left are the QEEG people, and the gray bars primarily on the right are the drug people. So let's take it from the left. Of the QEEG group, 54% had no migraines at all a year later, and they were off of their medication. Another 39% had a greater than 50% reduction in their headaches and were off their medication a year later. So if we add those two together, we get 90, 50, 80, 90, in excess of 90%, 93% of the people who opted for neurofeedback had either no headaches or a greater than 50% reduction in headaches a year later and were off of their drugs. So now let's see what happened to the people who stayed on drugs. Go to the right. 68% of them had no change. They're still on the medication and they're saying there's no change. That only happened to 2% of the neurofeedbackers. Feedbackers said there's no change. 24% of the people who stayed on the drug said, well, I had less than a 50% reduction, a modest reduction. And only 4% of the QEEGers experienced that very modest improvement. Now, of the people who stayed on drugs, only 8% said I got a greater than 50% reduction. So contrast the 8% who had a 50% or greater reduction on drugs with the 93% who had a 50% or greater reduction on QEEG, on neurofeedback. So what you really want to picture this as is that these are the intersections of two tails, of two bell curves. And so there's an enormous bell curve over on the right full of the drug users, and another enormous bell curve way over on the left consisting of the neurofeedback people. And picture in your mind how those tails overlap. There's a very, very slight overlap of the tails. This is not a small effect. This is a very large effect, a very large difference. And I wrote a letter to the editor of this journal. I had Bob Thatcher co-author it with me, and we calculated the p-value for this result. We calculated it in 3 different ways. And no matter how you calculate it, it's 0.0001. So that means you would have to do this experiment 10,000 times in order to get a result like this by pure chance. So this is a really nice result showing that, again, if you don't even have to do a blind study. You don't have to do a controlled study. You can offer clients an alternative and stay within ethical boundaries, because ironically the ethical thing to do was to keep them on their medication because that's the standard of practice. But this shows very clearly that if you offer this particular alternative to this group with the high beta, you could be looking at 90% success rates using neurofeedback for migraine. And I don't think you can necessarily look at that without some sort of pre-screening, pre-evaluation. So I'm going to do a summary. I will flip you through the reference list, of which there's 10 pages of references in your handouts, which you can enjoy ferreting those papers out. I have most of them on PDFs. I'm happy to share. But with ADHD, ADD, we have subtyping and we have differential response to stimulants. We find that the slow wave variants respond to the stimulants. Again, if you go to Suffin and Emery, their 1990s work, you'll see that it's excess of 90% effectiveness. Depression, the frontal asymmetry type responds to antidepressants. And you want to avoid SSRIs when there is excess beta or spindling beta. It's a warning sign. With respect to migraines, what we're finding is that the medication is of a very limited long-term value. If it's not working initially, there's a very low likelihood that it's going to help if you just stick with it. But in this case, EEG can be used to select neurofeedback. So if you have a migraine client and they're not working on the medications, and you run EEG and you see spotches of excess beta, you can be pretty sure that it's not going to be of very much benefit to keep them on whatever they're on, because it's not really doing it for them. So here's the page 1 of the references. These are articles by Arns, Gunkelman, and others. I encourage you to dig these out. Here's a report by Landsberg talking about theta-beta ratio and how it has the relationship to the slow alpha peak frequency, how you want to keep them separated in your mind. Paper by Sander and Heggerl talking about the EEG vigilance model and the response to stimulants. when you have this excess vigilance control, then they don't want stimulants. It's not going to help. More papers. This is on prefrontal cortants and antidepressants. Paper on prefrontal theta cortants and depression. And Benedetti and others on this MET polymorphism. And this is what we were talking about, the spindling beta. This is a particular genetic polymorphism affecting the antidepressant response, and you can see it in the EEG. Paper by Bruder and al. On alpha measures predicting response to SSRIs. Another paper by Bruder talking about asymmetry differences and responders and non-responders to SSRIs. Chabot, beautiful paper with Leslie Pritchett, Roy John, and a notable paper on using EEG in the evaluation of learning and attention disorders, and another paper with Serfontein on profiles of children with ADD. Some papers by Clark and others on ADD and different subtypes, differences of subtypes, and how the EEG defines them and how they respond differently to stimulation. So you can see that some of this is not brand new. These papers are 2001, 2003. Cook has a paper on changes in prefrontal activity characterizing the response to the antidepressants. And here's the Di Battista paper that I showed you. Here's the citation for it. There's 3 papers by IOC Fescue at Harvard, prediction of response to antidepressants, relatively recent papers, frontal EEG predictors of treatment outcome. Here's the John Stone and Lunt paper in Rob Cobin's book on the use of quantitative EEG. So Cobin's book actually has 2 nice chapters on this. In addition to Arns and Gunkelman, this John Stone and Lunt. And here's the paper by Korb on the rostral anterior cingulate cortical current density and response to antidepressants, similar to the report we saw with Davidson and the others on it. Paper by Luchter on comparative effectiveness of biomarkers and clinical indicators for predicting outcomes of SSRI treatment. Here are 2 Pizzagalli papers. This is the same paper. I started typing it twice, but this is the paper I showed you on anterior cingulate activity as a predictor of the response in major depression. And that's it. So I'm going to give this back to Judy. I see someone has a question. Judy, would you open up the speakers so that we could have a question, and if I can't answer it, we'll see if some... Judy, are you there to take the floor for us?
I am here. Yes, we had a question early on, but let me get back to him right now. David Pierny, I'm going to unmute you. David Pierny, I have unmuted you. Please ask your question.
Actually, at the beginning, we were just trying the button to ask some question.
Yes, well, now is the time.
Yeah, but I lost something about the use of QEEG in migraine. It's correct if I say that generally it's indicated to use neurofeedback in migraine when we see excess of beta in the EEG.
Absolutely, yes, and that the Walker study shows that very clearly, yes.
And this pattern is common to people with migraine, or just some people have this pattern?
Just some. Just some.
Just some.
I don't know the exact number, and that's a very interesting question of what percentage of migraine patients have the excess beta, and I don't know the answer to that specifically.
Okay. Thank you, Tom.
We have another question from Carlson Theodore. Carlson, I'm going to unmute you now. Carlson?
Yes.
Your question now? Carlson, go ahead. Carlson, we can't hear you.
That's right. I can't hear you either. Damn it.
Yes, you should be able to. Did you type it in a question pane? Oh, yes, here it is. It's in the question pane. Just to explain the three-letter acronym B as in boy, D as in dog, I as in ink.
Where did we see that? BDI?
Mm-hmm.
Yes, BDI. Carlson, where did we see that?
Oh, Beck Depression Inventory. The BDI is a questionnaire called the Beck Depression Inventory.
Okay.
It is a standardized assessment tool which consists of self-report by the client and then creates a measure of depression, combination of self-report, and it is considered a valid instrument, probably one of the more valid of the self-report types of depression inventories, the Beck Depression Inventory.
Thank you. We have another question. Are you aware of any studies using QEEG to guide treatment of schizophrenia?
I suggest you look up my friend in Turkey, Tanju Sürmeli, and he is using EEG for schizophrenia in Turkey. It's S-U-R-M-E-L-A. Here, I'll type his name into the box. Let me see. I will send it to...
You can find him. You can find him on our website, bcia.org, because he's BCIA certified. So if you go into bcia.org, find a practitioner, type in Turkey if you'd like, you'll find him.
He's a wonderful gentleman. He's very dedicated. He does a lot of work with schizophrenics. And he, in my awareness, is pretty much the leading person using neurofeedback with that population. It's a very, very difficult population. You know, this is an axis 2 disorder. It's not a simple brain dysregulation, you know, depression, anxiety, attention type of thing. It's, you know, it's a little more deep-seated. But yes, and find literature by Sürmeli. You'll search him out on the web, and I'm sure you're going to find a handful of papers. And I think he's coming to ISNR this year, but I'm not sure.
No, I think he is too.
Yeah, he comes to the meetings.
We have another question. Are you aware of any recent studies using QEEG treating PTSD?
QEEG with PTSD. I certainly know of, I would think there'd have to be some, but they're not coming to mind right now. If someone else has a name off the tip of their tongue, can they type it into their text box and Judy could relay it to the group? I'm struggling because I know people are coming in and out of this. I know that Thatcher is working with PTSD, and obviously there's a lot of this in the military. I'll tell you what the problem with PTSD is, though. Recovery from PTSD is a process, and it is not a simple question of normalizing the EEG. So if you can, his best friend either be blown up or have his legs shot off or have their own legs shot off, and now they're processing all this information, and their brain is now adjusting to a hypervigilant, depressed, anxious, worried state. Just changing the EEG back where it started is not going to fix the problem. So PTSD, in my view, needs to be handled with a lot of cognitive behavioral work, EMDR, eye movement desensitization reprocessing work, probably REBT, rational emotive behavior work, and alpha theta training to get processing through all of this experience, I would be very cautious about thinking that the same type of QEEG approach that will alleviate anxiety or even improve attention, I would be very cautious at assuming that that same approach is going to fix the whole constellation of things that have produced PTSD. But I know you're going to find research on it. There are individuals doing it, particularly in the military.
Thank you. We have another question. What would you recommend for high frontal spindling patients?
We recommend neurofeedback to reduce that spindling beta. And did I get to a possible direction on medication with them? I believe one of these. Yeah, I think neurofeedback is obviously a recommended option when you do see that, but by basically down training that spindling beta, and I would think rather than stimulants, you want to give them quite possibly things that are more relaxing, more sedatives. So I would consider sedatives that are also part of the clinical constellation of options. When you see that, I would move them in the direction of more of a sedative. In fact, if we go back here to this, these are all depressed, and as you can see, some of them are actually being given what are more sedatives, or even anticonvulsants.
Okay, thank you.
Definitely not stimulants. Definitely not stimulants, definitely not SSRIs.
We have another question. In the studies cited, especially the Walker study, did the experimental subjects stop taking all meds cold turkey?
I don't know if it was all cold turkey, but they were off the meds by the end. As I recall the paper, they did not cold turkey. They were weaned off of their meds as they experienced improvement to the neurofeedback. No, I don't think they cold turkey them, but they were all off by the end.
Okay. Two more comments.
That's another important point. Yeah, I just want to reinforce that point that if you're alternative or in conjunction with medicine, I don't think anyone would recommend that you cold turkey, and that's a problem with the CNS response, is that you've got to wash them off the drugs in order to get the EEG, and that's not even practical in a lot of cases.
Another few comments on PTSD. Someone said that they believe that the VA is working on that, and I absolutely agree. And then weren't there studies done at Menninger that did neurofeedback with prisoners with PTSD with positive results?
Possibly, and it would very likely have been alpha theta training then, or alpha training. It would have been a very integrated approach at Menninger.
Another question.
I mean, I even think that Peniston worked with some PTSD because alcoholism and drug morbid.
Could you review when the use of antidepressants are contraindicated for children with ADHD?
Wow, that's an interesting way to put it. I guess it would depend on the antidepressants. Contraindicated. Well, I would certainly not use SSRIs wherever you see a low voltage type of EEG. This is low voltage. So I would specifically say that where you see the low voltage EEG, here this slide talks about, where you see low voltage, I would definitely not be using SSRIs with them. I don't know about other antidepressants in this specific population, but I encourage people to pull out all the references that are there, and that they might find the answer in one of them.
We have another question. When do we use alpha protocol for treatment of ADHD?
What they said in the ARNS paper is that they used it when there was a deficit of alpha, I believe. And I don't mean to be glib. They saw a signature that was deficit of alpha, to go back to the ARNS paper itself. But generally, they were doing alpha training when there was quite simply it was the low alpha variant of ADHD, which indicated basically these kids were hyperactivated, and that was their problem.
Have there been any QEEG medication studies concerning addiction and chronic pain?
The only one I know of is Jeannie Bodenhamer and Richard Davis have looked at QEEG-based treatment for addiction, and what they do is they normalize the EEG in conjunction with the addiction treatment to reduce cravings, to brain activity. So the first question was addiction. So yes, Jeannie Bodenhamer. And what was the second disorder? You said addiction?
I did, and I deleted the question. I'm so sorry.
That's okay. I think that one I didn't know.
Okay. Well, we've gone about 7 minutes over our time, well, about 5 minutes over our time. Tom, can you stay a little while longer? I know you have an appointment.
I can stay a little while longer. We thanks everybody for adjusting to our time change, and it's sufficient that I don't have to rush out of here in blazing speed. So yes, I can stay a little bit.
Thank you so much. What is the neurofeedback research results for eating disorders?
Wow. I don't know. That was easy to answer. I apologize. I'm not aware of it. We should dig into that one.
This is more of a comment, but somebody said that they use emotional freedom technique with neurofeedback for PTSD with good results.
Absolutely. Absolutely. Good. Thank you for that.
And another question, what is the interpretation of alpha excess in anxiety?
The interpretation of alpha excess in anxiety is that it is a coping mechanism. It is a masking mechanism. And the person is not comfortable with this chronic, it's in chronic anxiety, not episodal or adjustment disorder with anxious features. It's when there's chronic anxiety, and this becomes a mechanism to basically cloud the awareness of the anxiety. So the person is still anxious, but they're generating all this alpha as a way to just kind of mud it over with a relaxed state. And as you know, any part of the brain that spends a lot of time in alpha is offline. It's not doing its work. So it is a general coping mechanism that masks this chronic anxiety, and if you train it down, you could cause I want to say an abreaction, but because it's the proper reaction. It's that the coping mechanism has been reduced, the brain reactivates, and now the person gets more anxious. And I do know anecdotal reports of people who have had their, both in chronic pain and in chronic anxiety, anecdotal reports of people who had their EEG normalized by reducing the alpha range, particularly if it's in the front, and then they go off and they do crazy things like jump in their car and drive for 14 hours to Reno, Nevada, and do crazy things because they're used to being blocked out.
We have a very good group of listeners, and they reminded me that the question where it was, has there been any medication, QEEG medication studies on something, and we didn't know we couldn't remember what the second thing was. It was chronic pain. Remember that question?
Yeah, well, I'm not aware. Yes, what's being done in chronic pain now is limbic and frontal training. Mark Smith, who works with us, and he's doing a lot of Loretta training, trains focally, and he trains down beta in the starting to go into the insula. So chronic pain has been a very, very, very difficult one to cope with, and Mark is now, and some of our European friends also, who are using S-Loretta as a live, real-time training method, are now training those central structures and basically training down beta, and those methods seem to be effective in chronic pain. Just normalizing the EEG, the surface EEG, has not been a tremendously successful strategy for chronic pain. But in doing Loretta, S-Loretta work on these other structures, cingulate and insula, are now showing results, positive results in actually not a lot of sessions. We're looking at 3, 4, 5, or 10 sessions for relief of some of the chronic pain. So I would stay tuned with tomorrow.
We have 2 more questions, and then I think we should cut it off. Dr. Collura has been so gracious to stay on with us. And here's the first one. If children are on 4 different meds, this is going to confound neurofeedback and even the cue, right?
Absolutely, it's going to confound the cue, and it's going to confound a lot of things. And this is one of the things that EEG can help us do, is to stop using cocktails. The reason they're on multiple meds is because, first of all, you have what we call comorbidity. To me, comorbidity exists largely because our vocabulary is so deficient. I mean, it is a person with that person's constellation of problems. We try to slap labels on it. It's like music. You go, what is it? Is this pop? Is it rock? Is it folk? What is it? Well, it's pop, rock, folk. No, it isn't. It's music. It's this person. The concept of comorbidity points to a problem in classifying. So then we start throwing different medications at them. So a kid might, be having an attention problem, but he's depressed because he's not doing well in school, and then he's anxious because he gets his, yelled at every time he does something wrong. So now you're giving him an antidepressant, and then they want to give him an anxiolytic because he got anxious, because he's guilty and feels terrible about taking drugs. So now he's anxious because he's a druggie, and these cocktails begin to just compete with each other. But absolutely, anybody who's on 3 and 4 medications, the QEEG is going to be highly suspect. And obviously a nice goal would be to start to taper them back, especially kids whose brains aren't even developed. We don't even know the effect of 1 medication on the growing brain, much less 2 and 3. So absolutely, it's a problem.
Thank you. This is our last question, and then I have a couple comments. I have a kid on sertraline with pretty severe anxiety, and he has huge low alpha spikes on T3 and T4, bigger on T3. Any ideas for what sort of training to do?
Well, you're going to want to train down that temporal alpha. That is, of course, a phenotype. The excess temporal alpha, and as we've seen, it's associated with OCD, other types of problems. You want to consult with a good doc. Get somebody good on your side. The Thompsons, Jonathan Walker, Harry Karasides, Jay Gunkelman. You know, there's a lot of people who are out there who can give you some good expert advice, a lot better than I certainly can. But I would seek some good consultation, but certainly the phenotype recommendation is to train down that temporal alpha primarily. But I would go back to the papers by Johnstone and look what they also say about the excess alpha, temporal alpha.
Well, that concludes our presentation, and thank you all for your questions. There were a couple great comments that we did receive. Thank you very much for a well-organized, clear, and concise presentation. Great talk. Thank you. And then we had quite a few people who were interested in the PDFs that you mentioned. You said you had copies. So, Dr. Collura, you and I will talk privately about how best to get this to the people, and then I will send an email out to the group.
I want to talk fast. Yeah, let's talk about that. Technically, this is copyrighted material, and I don't want to wholesale give away links to all my PDFs, but we're certainly happy to distribute PDFs as appropriate. So, Judy, let's you and I talk about how we can coordinate that and remain within the bounds of copyright and ethics.
Exactly. That's why I said you and I would speak about it, and then we'll talk about any conclusions that we have. So that concludes our presentation. Dr. Collura, I cannot thank you enough. I think everybody here would say that it was a wonderful, worthwhile part of our day, probably the best part of all of our day. So we thank you. We hope that you will all stay tuned for more webinars coming from BCIA, and we hope that you'll find this to be a good way to learn and stay current. So thank you so much, Dr. Collura. I'm going to end the presentation for all of us. Have a wonderful evening. Take care.
Good night, all.